Well, welcome everyone. Thank you for joining the Research in Progress webinar series for the Robert Wood Johnson Foundation's Systems for Action Research Program. As we always do, we have a very exciting research project and research team to hear from today. One of our many grantees who are testing strategies for aligning medical, social, and public health systems and studying the implementation and the impact of those system alignment strategies with a particular focus on improving population health and achieving health equity. If you're new with us on this webinar series, we do this about twice a month. We hear from one of our research teams about an ongoing Systems for Action research project, and really hear what teams are learning at all stages of the research process, whether they're early on in designing and implementing their studies, or whether they're wrapping things up and have more definitive findings to share. So this is an excellent way to the hour that you'll spend with us is an excellent way to keep tabs on what we're learning about how to align health and social systems, and understanding the implementation and the impact of innovative system alignment strategies. We will, so a little bit about logistics, we'll have the first part of our webinar hearing from members of the research team and their partners and stakeholders describing their studies and what they're learning. We will have time toward the end of the hour for some questions, to take questions from the field and to hear from our research teams. We'll be using the Q&A feature of the web system to do that. So you should, if you'd like to submit a question, you should be able to see down toward the bottom of your screen a Q&A button that you can click on and submit your questions. And we'll try to get to as many of those questions as we can during the latter part of the webinar today. For today's feature, Systems for Action study and research team, we're very pleased to have colleagues from the Texas A&M School of Public Health who are working with colleagues at the Cheyenne River Sioux Tribal Nation in studying a very innovative initiative called Weeding the Tasina Luta, a community-based participatory approach to systems alignment with a tribal public health plan. And specifically, we have several members of the research team with us today to step us through what they're learning, including Dr. David Washburn, who's an assistant professor in the Department of Health Policy and Management at Texas A&M School of Public Health. And he's got a long history of conducting health services research projects, focusing on issues like access to care for vulnerable populations, using a variety of methods and data sources, including some work and experience in working with tribal health programs, which is a major focus of the study we'll be talking about today. He's also joined by another collaborator in this project, Dr. Barbara Quiram, who is also with the Texas A&M School of Public Health, professor there, as well as director of the Office of Special Programs. And we also have with us Carpenter, who also works in the Office of Special Programs and Global Health, as well as the USA Center for Rural Public Health Preparedness at Texas A&M. And Kay has some particular experience in working with tribal systems and tribal populations in the area of public health preparedness and emergency response. And we also will, I believe, today hear from Harold Tiger, who's a health education instructor, another active collaborator in this research project. So I think without further ado, I would like to turn it over to our research team and to Dr. Washburn in particular to kick us off today.
Great. Thank you very much, Glenn and Carrington. And I think Harold has called in now as well, if I can see correctly from the participants list. But thank you all for being here and giving us this chance to share the work that we've been doing with Harold and others in the Cheyenne River Sioux Tribe in South Dakota. A few years ago, in the fall, the Tribal Health Council signed on to what's known as the Tichina Luta, which is the first sort of tribal public health program that the Cheyenne River Sioux Tribe has sort of locally developed and sort of begun implementation. And it's sort of without sort of any external drivers. This was something that the tribe really started up and developed themselves. And there are 4 pillars to this public health program, the Tichina Luta. And we'll talk a little bit about each of them. And one is to try to ensure that all tribe members are getting an annual health review, and whether that health review is a full physical or not, but just to get people actually to go to the doctor, to see their providers. There is a lack of engagement with the healthcare system for many tribe members. There is a second pillar of the Tichina Luta is this notion of developing health-wise handbooks that individuals and families can have within their home to encourage sort of personal engagement with health, especially in an area that's as rural as I'll soon demonstrate, where distance to providers is oftentimes very long, and sometimes there are concerns about the way that people have engaged with the healthcare system in the past. Another pillar, the third pillar, is this 24-hour Ask a Nurse hotline that the tribe is interested in pursuing, where people, again, from the comforts of their own homes or where they can actually find cell reception, call and ask a nurse before you make the long trip to an emergency department or a provider should you be ill. No one wants to travel an hour and a half to go to a provider only to be turned away saying you didn't really need to come in the first place. Then you have to drive another hour and a half back home. That's a lot of driving for nothing. And then fourth, which has been implemented already for the past 2 years now, the tribe is putting together an annual health summit of providers, including private providers around the reservation and nearby. This is something that is still ongoing. And it's a way to also get collaboration across different healthcare systems, not just those that like are the IHS. Let's see, I can control the screen here. Okay, and in general, these 4 pillars are really about encouraging people to access care, to get people to engage in the healthcare system and have collaboration across providers in a seamless way that encourages people to want to engage in a healthcare system where unfortunately levels of engagement have traditionally been relatively low. Let's see how I can, there we go, next. Okay. So the Tichina Luta was initially developed and written by Margaret Badwarrior, who is not able to join us today, but it was signed off on, as I mentioned, by the Cheyenne River Sioux Tribal Health Council. I believe it was back in fall of 2016. Tribal Health and A&M collaborated on facilitating the first annual health summit in 2017. Kay and Harold have been working together for approximately 12 or more years now on public health and emergency preparedness. And through their sort of collaborative efforts and this new program with the Tichina Luta, we offered to also help with a collaborative community-based participatory research effort to assist with the implementation of this innovative new initiative, the Tichina Luta. And I'll go into the details a little bit more about our methods and our findings later, but I also wanted to give you a little bit of background of just about where we're talking about. So here you can see a map of life expectancy at birth from 2014, and you can see sort of in the southeast, outcomes aren't as strong as they are in places like Denver or Boulder, Colorado, where you sort of see that deep blue. And also when you look at South Dakota, a lot of the more redder or oranger colors are tribal lands. And in fact, I'll zoom in here in a little bit, but the 2 counties that are part of the Cheyenne River Sioux Tribe had life expectancy rates of 71.02, which was the 12th lowest for counties in the United States, and then 76.39 in the other county, which also had the second lowest per capita income in the continental U.S. These are, of course, both lower than U.S. averages, and Dewey County's life expectancy of just 71 falls between the national levels of Turkmenistan and North Korea. So again, you know, within sort of between county disparities are pretty significant, and you know, there are parts of the United States where we are not achieving the type of health outcomes that we would really like to see. And part of that is, you know, trying to get people to engage in systems that they trust, they believe in on a regular basis, so that their health can be maintained and sustained over time. So I just highlighted there in red, those are the two counties that I've referenced. You can see they don't have the lowest life expectancy rates of all of the counties in South Dakota. Some of the other places include Pine Ridge, sort of down there in the southwest. The Cheyenne River Sioux Tribe does, you can see that it's, you know, those are more orange than blue, and their life expectancy rates, unfortunately, have been lower than we would like to see. Okay, a little bit more just about the Cheyenne River Sioux Tribe. It is a population of only about 8,000 people, maybe a little bit more than that now. It is, however, a very large geographic area, which is only slightly smaller in land area than Connecticut. In the middle, you can kind of see there in the map, is Eagle Butte, and that's there's about 1,300, 1,400 people that live there, and that's where the IHS hospital is, the Indian Health Services Hospital, a few of the other providers. Tribal Health is also located there. That really is sort of the administrative center of the Cheyenne River Sioux Tribe. I'd mentioned before, there are also private providers sort of off the reservation if you want to go find larger hospitals. They are a few hours away in Pierre, South Dakota, Rapid City, and Bismarck, North Dakota. But it's about, you know, an hour and a half maybe to Pierre, to some of and maybe 2 hours to Rapid with a larger hospital, with larger hospital systems and networks, maybe 2 to Bismarck as well, maybe a little bit more. So travel times, and it also depends on where you are talking about leaving from the reservation. Even going from, you know, where the roads are determine also how long it's going to take you to get from one place to another. So if you're sort of in the far northwest part of the reservation, you want to get to Eagle Butte, it might actually take you an hour and a half just to cross that distance, because there are no straight lines, or the straight lines aren't going in the direction that you would if you were a bird and could fly there, right? Okay, so what was the focus of our project? Our job was to try to gather information from local experts and tribe members regarding how would they envision facilitating the implementation of this first locally driven public health plan, the Tichina Luta. What are the types of strategies that tribe members think would be beneficial in reaching out to community members, including those that have historically perhaps not been as engaged as people would like them to be. So this was a CBPR model where community members were providing guidance for the implementation of the plan. Our job was really kind of gathering market research to help push implementation of this new initiative forward. You know, implementation is really where the rubber hits the road, and anytime there's a new initiative like this that hasn't been attempted in the same way before, it's important to sort of step back and think, okay, well, let's actually talk to our clients, our customers, those people that we're actually responsible to, and get a sense before we start and go down the wrong path, what are some strategies that they would recommend that we pursue? After all, those are the people that you are trying to reach. But we didn't just speak to clients, we also spoke to key stakeholders. We had about 14 key stakeholder interviews, which we recorded and coded in vivo and did qualitative analysis. They were about an hour each, some were a little bit longer. And we spoke to a lot of community leaders, including Harold and many of his contacts, people who work for Indian Health Services, people who work for the state of South Dakota, but really the vast majority of these interviews were with tribal leaders that are somehow engaged with the health of the tribe, of the Cheyenne River Sioux Tribe. You can see some of the different issues that we covered there. including prioritization of different implementation efforts, how to encourage individuals to engage. This is really asking the experts, people who have done community outreach, how do you get people engaged? What are the best mechanisms that you found for getting people to alter their health-seeking behavior? We also conducted 5 focus groups. 4 of these focus groups were with community members, and 1 was with the community health representatives, which are community health workers who work for tribal health, and they have a lot of experience doing outreach and dealing with issues of transportation and getting people access to care across the reservation. And again, we covered many of the same issues. What are effective outreach methods, whether you're a community health worker or somebody who has interacted with the community health representatives or other tribe members in trying to promote different health initiatives, or health educators like Harold. And also questions of sort of why and when do people actually choose to access medical care? What are some of the barriers that have prevented them from accessing care when it's needed? And then, how do people encourage their friends, family members, or even themselves to become more involved in their own health? And we conducted the focus groups in those different locations. We wanted some geographic diversity across the reservation. We had 2 focus groups in Eagle Butte because the community health representatives are based there out of the sort of the main hospital in Eagle Butte. And we were able to do some down there in the far southwest in Bridger, where you can also kind of see from the main highways, actually going through the reservation from Bridger to Eagle Butte, you actually go off the reservation and then you come back into it in some of the routes that you would take to actually get to the administrative center. So for folks from those locations, accessing care elsewhere sometimes might actually be a little bit easier. Okay. So what are some of the themes? I've referenced a few of these as we've spoken so far, but one of the things that came up sort of over and over again, especially as it relates to some of the challenges in achieving better health outcomes, the importance of getting people to access care before it's too late. And I'll try to read through a few of these quotes. So one of our respondents, who was a healthcare professional, said, "Where I work, there are a lot that disregard their health, even if there is an existing or pre-existing medical condition, and they may cover it up with alcohol and drugs. So by the time they decide to sober up, it's already in a bad stage. We don't get them here until, like I said, middle 3/4 or end stage sclerosis." Right? So there's a lot of delaying happening. We have a huge no-show rate on just our diabetics that need to come every 3 months, or our cardiac patients that need to come every 6 months to a year, depending on what they are for their annual EKG or whatever. It's not easy to get people into their appointments. So this, the challenges of engagement was really a theme that we heard in all of our interviews. And there were a lot of reasons for that, whether it was transportation or lack of trust. And sometimes here, that kind of gets touched on a little bit. In this theme, the divisions between health systems. There's at times been a division in providing health care between our private sector, tribal, and Indian health services, and it's widely known that it happens. Some people just refuse to come to tribal health or IHS. They want to go to private providers because something happened here that they didn't like, and we don't have consistent providers at IHS. The hospital in Eagle Butte does have a lot of turnover. If somebody has a primary care provider that they've learned to trust over time at IHS, sometimes those folks rotate to other systems or they leave for other jobs. So there wasn't as much of a sense of sort of co-ownership, or we heard a number of complaints, especially about the sort of the turnover issue. And then one of the reasons for one of the pillars of the Tichina Luta is hearing things like this, that private providers are kind of doing their own thing, IHS is doing its own thing, and even though tribal health is actually within the same building as IHS, they're not always working hand in hand, but they do try to as best as they can. But there are still some divisions and breakdowns, which for the client who might have to drive in an hour and 15 minutes to any of these different providers, it sort of demonstrates what could be perceived as a disjointed system that's not necessarily looking out for their best interest, or that at least could be the perception, and therefore engagement levels stay relatively low. So there are a fair number of projects that have relied upon incentives to get people to engage with their healthcare system. I know that for myself, I need to go and have a primary care checkup here so that my deductible is decreased by either $30 or $50 a month for the next year, which I need to get on that. Unfortunately, I've been a little busy. But similarly, incentives are important for people to, especially in low engagement areas, their incentives are important to get people to engage. And here were some quotes that we had to that point. To get them there, or sometimes to get people to participate, you may have to offer an incentive. I hate to say that we are incentive driven, but it is what may make a difference between somebody participating and somebody not participating. I look at it in two different ways. One, that we are incentive driven, but we are also trying to survive. And recall also that sort of the family income levels in this area are also very low, and there are economic opportunities are sometimes few and far between. Next quote, we kind of got into this rut where you have to either offer food or incentives. I shouldn't probably say a rut, but it seems like when we do have functions and we don't offer that, we are not getting a good turnout. And then maybe you look with our addictions and people on a fixed income coming to eat. In the Lakota culture alone, if you feed them, then that's an honor as well. So there are also cultural reasons for, you know, you have a feed, you have a meal. In fact, for our focus groups, we also wanted to make sure that we were offering food in a culturally appropriate manner. Okay, so with all of these challenges, we also have communication and connectivity challenges, and it is also very expensive and limited. You know, we're talking about an area the size of the state of Connecticut, but some people, and here's the quote, I have to drive up to 2 miles to go up to get internet. So we do have a hill, and they call that cell phone hill, where you will see a lot of people parked and accessing. And if somebody's on a fixed income, because I could tell you right now, I personally have internet at my home, but I pay over $100 a month. So if they're on a fixed income, they're not having internet in the home. So this also presents challenges when you're trying to sort of promote new initiatives. And you know, a lot of people do use social media, but it's not universally accessible sort of across the reservation. Certainly those that are in places like Eagle Butte or some of the other towns have a much easier time than those that live in some of the smaller communities where you have to travel a couple miles just to even get a signal. Another theme is that persistence matters, but it also unfortunately has a bad track record according to some of our respondents. We have to be consistent because one of the biggest complaints is that we try to introduce something and then it never follows through, right? And so this again, sort of implementation is where the rubber hits the road. So being strategic in how you implement something is very, very important, especially if other projects in the past have, you know, sort of started up and then sputtered out, and even that affects sort of long-term trust and confidence across the community. Another theme about outreach, and just thinking about sort of the strategies that you might use to get people engaged, especially when you're talking about very different generations of individuals. One of the quotes we had was, our population here are a lot of hands-on. If you see a piece of paper like this, which we had brought sort of little documentations explaining what, a little piece of documentation explaining what the Tichina Luta's pillars were. And if people don't understand that, then they will just push it to the side. People prefer a lot of visual, and if somebody also talks about it, that would be better. And then also getting out there and going to each district. And maybe that's where the community health representatives and health educators like Harold could really help. It's very important to have trusted members of the community engaging with community members, also not just in sort of the main administrative center, but all in the communities where people reside, going out to the community centers, which is where we did a lot of our focus groups, and meeting people within their own communities. I think that helps to just build a level of confidence that's necessary, especially when confidence has wavered in the past. Communication methods have also changed over time, of course, and we all know this, but it also affects the way that you might try to outreach to individuals. And here was a quote, when I was a kid, we went on weekends, on Saturday or Sunday afternoons, you would go and visit your neighbor and have coffee and play cards. And you just don't see that as much anymore. It seems that people are too busy, or maybe because of social media, they value their privacy a little bit more. So it's not as acceptable anymore to just drop in on somebody. We don't gather like we used to. There certainly are gatherings, formal gatherings that still do take place, but this kind of informal place where you might imagine sort of communication traveling through social networks about different programs or benefits or possibilities that people could avail themselves of don't happen in those informal experiences, informal ways as much as they perhaps could have in the past. Also, another theme is that cultural awareness is the foundation of outreach. Somebody mentioned to us where there was a Caucasian preacher who came right up to me, and she was right in my face, and I was like, whoa, 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 you don't do that in our culture. And you also don't try to match eye for eye. Eye contact is something very different. The respondent was also saying that they're comfortable with eye contact, but here it's taught as being very rude, and that is, you know, to really stare somebody right in the face. And then in other situations, sort of on the outside, they're saying you're not being honest because you're not looking at me right in the eye. But even that sort of level of sort of cultural awareness is incredibly important for anybody who will be going out to promote a public health program, which of course, when you have individuals like Harold or the community health representatives who live on the reservation who are doing that work, they're aware of all of those types of issues in a way that this Caucasian preacher wouldn't have been otherwise. Approach and style matter, especially when trust has broken down with vulnerable groups, is another theme. So one of another community health, somebody who works on health-related issues within the community mentioned that they did this exercise with some young people who were a somewhat challenged. They were a challenging group. They were somewhat disengaged, and they didn't have a whole lot of trust, even with that individual at that time. And he was doing an exercise. He said, "I'm going to walk through this door," and he would just ask all of the young folks that he was working with to tell him when to stop when they're uncomfortable. There was a young lady in the corner over there, and I was about a halfway step in, and she said to stop. That was her comfort zone. And then with one of the young men, who was the ultimate gangster, he got in 3 steps, and then he said stop. And just this notion of being sort of too upfront, too much in people's faces, especially when when trust has broken down, it really is going to influence the way that you pursue engagement. When you're trying to ultimately increase engagement with the healthcare system, that sometimes people have lost their trust with. Okay. A few other themes before we get to the end here. I think I'm getting close. We heard a lot about the importance of Medicaid. South Dakota is a non-expansion state, but a lot of the folks still fall, they're below the lines where they still qualify for Medicaid. And if you recall from my map earlier, Bridger is on that southwest corner of the reservation. It's much closer to healthcare off the reservation in other places. So for the lucky, in this case, many, 70–80% of Bridger approximately have Medicaid, they go to Phillip for care. So they don't necessarily engage with the healthcare system in Eagle Butte and the Indian Health Service as much. They might go to private providers off the reservation in another town called Phillip, or they might go to Rapid City, which is even a little bit further away, although not too much further away since Bridger is already in that direction. But for those who don't have Medicaid, and if they wanted to go for emergency care off the reservation, IHS will cover that sometimes, but if you go and it's determined after the fact that IHS, that's not their responsibility to cover that particular visit, then who's left with the bill? So that's very risky to do that, and you might end up getting stuck with the bill, a month or so later, that IHS has denied your claim because you went to a private provider when you should have gone to Eagle Butte, which was perhaps even a little bit further away. So these are tough decisions for people to make, especially in a situation where you might need emergency care in the very near future. Let's see if I can change the slide again. There we go. Of course, transportation is a challenge for many. And And if we're really trying to promote the idea of doing annual health reviews, they might have to happen not in sort of the main administrative center. If you want to encourage people to go all the way to Eagle Butte for doing annual health reviews, that may not be effective. So we've been talking about ways to actually conduct those in some of the smaller health clinics that there are a few of across the reservation in some of the somewhat larger towns. Targeting those that are already engaged with their health will be very easy, but getting others who just are very not engaged at this time, that's sort of the crux of this issue. This is going to be a big challenge. Social media is widely used among many youth and the working class who have connectivity, but the radio reaches an even broader audience. And actually our commentator, Harold, hopefully will be able to speak to this a little bit. I'm excited to hear a little bit about the work that he's been doing on the radio over the past several months now. And then if you're trying to work with elders, face-to-face or community events, sort of those more traditional ways of reaching out to folks through promotion might be more effective. Okay, so next we have a publication in the works that's really focusing on intersectionality theory and health access and health-seeking behavior on the CRST reservation. And intersectionality theory is really, it's about, you know, just having a low level of income is one thing. Having challenges of transportation is another thing. But if you actually have both of those things, the barrier that presents is greater than the sum of its parts, right? And so particularly in marginalized situations, there are a lot of times where, you know, if I have enough money and I can help to pay my neighbor who has a car for gas, perhaps they can help me with transportation. But you know, if I don't have either, then that becomes a little bit more difficult. That type of notion. We're also having conversations with the tribe on seeking additional funding to implement and evaluate different campaigns and perhaps incentives, which are politically challenging, but we've had discussions about this, to really encourage individuals to get their annual health reviews. So we're talking, we have had a conversation with some epidemiologists that work with Robert Wood Johnson Foundation about how we could design and then test different promotional campaigns, whether sort of with this wedge and looking at different, doing sort of timing the geographic focus in different areas, or just other opportunities for actually testing and then measuring, okay, what is the impact? Have we changed the rate of people seeking healthcare, or at least going to get their annual health reviews, and what types of initiatives have been most effective and for which populations or which generations across the reservation. And I think that's probably my last slide, I believe, if I recall correctly. Oops. I could just went back a bunch. Yeah. Okay. And then I guess Harold, I think that the next person to comment on the presentation thus far would be Harold, if I'm not incorrect.
Yeah, that would be great. Let's. We are going to have some time for questions in just a moment, but I believe we have another important collaborator, Harold Tiger, with us to offer some additional commentary on this work to date. So, Harold, if you're with us, we'd love to give you the microphone for a little bit.
Well, thank you very much. Again, my name is Harold Tiger. I'm the health educator and instructor trainer for the tribe, and been working at several ways to try and implement. And I appreciate the help of Texas A&M and Kate Carpenter and all her team to try to implement some of these things that I think that are important to try and get our tribal members to access, like I said, our health care system. I've been working for the emergency management system. I've been a medic for the tribe here for 32 years and gone on several calls, so I see a lot of this stuff that they're talking about in reference to the healthcare system. I know that there needs to be some kind of improvement here, and I was very happy that Mrs. Peggy Badwarrior had written up this plan sometime, in the past, but was never brought to light until she brought it to my attention, and I really start pushing it to get it implemented. And a lot of those issues are very true, what he said about the people here, because of, our doctors, like you said, a lot of our doctors are here just temporarily, and then they're gone again. So some of the stuff that they worked with the tribal people, started and quit because that physician is no longer here anymore. And so, I'm glad that we're able to try and do things here. And also, I'm a radio broadcaster I did it for KLND, which is our neighboring tribe, Standing Rock Sioux Tribe, and broadcasted a lot of information on their radio station. And now we have our own, so I do that every Saturday morning from 8 to 12, and I try to get out information to the public in reference to things for safety reasons, for health reasons. I get out information from the health department to the public by radio, because now our radio station is able to reach everybody. With KLND, it was only, we couldn't reach the western part of the Cheyenne River Sioux Tribe by radio. Now we have a stronger broadcasting system, so we're able to reach everybody and then some. So people off the reservation are hearing us too. But in reference to a lot of this stuff, especially this is some of the stuff that used to exist in the past when I was younger. The Health-Wise Handbook. I remember that when they handed it out. When you had a problem or something, you could look it up in a book, and then it told you whether you can, if you needed to call an ambulance right away, or if you should schedule an appointment for some kind of health problem. And then also, I really appreciate Kay in helping us start. We did an ice cream social to get all these clinics together to discuss and work on some of the existing health issues that we're dealing with, such as and I think it's across the country, is the meth issue, and and other things, And my goal is to just get them all collaborating and working together so that they could share information and be able to work as a team to try and work on some of these issues that we're having here. And then, in the past, we used to be able to call the hospital too, and then all of a sudden they weren't able to do that again to find out, if they should come in and get seen or not, because as you heard, some people really have trouble even getting transportation, or not even, some of them can't even afford a phone, so they have to borrow their neighbor's phone to call. So in the middle of the night, they're really a little hesitant to go and knock at the neighbor's door and wake them up for some reason. But so people are helping people here, and I think that doing all these things, and especially like the health review. I remember as a kid, we used to have to get have to come in and get a health review done, physical and everything once a year. And I feel that they're not doing that anymore. I don't know why, but it seems to me like we're doing a little bit of things backwards here. We're not doing preventive care as well as we should, and we're not spending a lot of that dollar amount on the preventive care. And it's more or less of, finding out that, people are in 4th or 5th stage cancer or other health issues, and then they're just seeing them on their way out, giving them comfort as they're dying. And I think that needs to be changed around. I think that we need to do more preventive care for the public. So, and this is what this Tasina Luta program really, kind of pushes. So, we're looking at, we're seeking help, and we're looking for ways to try and implement these programs. So, I'm very much an advocate for the tribal people here, and so I'm pushing to try and get these things done. I guess those are things that I've been working on most of my life here, because I've been working for the tribe as a medic for 32 years. So, and I'm a health educator. So, I'm looking for all the help that I can get to try and improve the healthcare system here. with the IHS and the tribal health systems. And I guess, in a nutshell, our presentator pretty much covered everything in reference to all these reviews and everything, and I was really grateful that they did that so they can get a better view and look at how we can try and implement and try and improve these healthcare programs. So, in light of that, I guess I'm here for any kind of questions that anybody might have in reference to that.
Fantastic. Thank you so much, Harold Tiger, as well as the rest of the research team for giving us this update on your study and what we're learning. We're going to move into the question and answer portion of today's webinar here shortly. Just a few kind of opening comments and maybe stimulating comments. First, as a reminder, there is a Q&A button on the bottom of your screen where you can submit questions to our panelists today. We encourage you to use that button here, and we'll get to those in just a moment. Just to reflect a little bit on what we've heard and maybe stimulate some thinking. Obviously, for all of our systems for action studies that are studying mechanisms for aligning medical care, public health, and social systems, we know from this large and growing body of work that context matters very importantly, and culture matters very importantly in terms of how you approach aligning medical care with social and public health systems. And this study in particular is a very important addition to our research portfolio because it's really the first study that Systems for Action has supported that looks specifically at the tribal context and the tribal culture and the issues around how to align systems in tribal context and in the context of the specific population and cultural issues. So the work you shared with us today really provides us with some very useful insight about not only about how to do multi-sector system alignment research in the context of tribal populations and with tribal populations, but also what some of those unique contextual factors are that we need to grapple with. I might take moderator's prerogative and throw out an initial question, which has to do with some of the findings that you referenced and described have to do with transportation issues and with communication issues and infrastructure and how they intersect with health systems. And so I wonder if you could maybe expand a little bit more, any of our panelists, on how this project is thinking about how to solve some of those challenges: lack of transportation infrastructure and limited communication infrastructure, whether it's cell phone or internet, some of the kind of issues that you mentioned there. How to tackle those problems and the health consequences that are generated from the lack of infrastructure in those two areas. Any more thoughts from our panelists on those issues?
Well, go ahead, Harold.
Oh, I'm sorry.
No.
I was gonna just implement. The tribe is trying to improve some transportation issues. They did get a transit system in place here, but then there again, our poverty levels here that people can't even afford to pay for tickets to ride the transit system. So, and then the communication issue, there again, we have departments that do go to like our elderly and some of the people with health issues and make visits with them to try and schedule things to try and improve our communications between the client and the hospital and their appointments. That's some of the stuff that they're doing here now.
Fantastic. Wonderful.
Yeah.
I think also that the radio, having the ability to reach everybody on the reservation now, the program that Harold does, and just the capacity that provides to communicate important messages, whether it's prevention or it has to do with some kind of public health emergency. I think it's been a real boon, hasn't it, Harold?
Oh yeah, it's really improved the communications through the tribes. And when I'm on my program, I do some training exercises on the air about what people can do to prepare for the things that might happen out in those communities, because most of our resources that our response system mainly all comes from Eagle Butte. There's nothing on the outer lining of the reservation that responds to some of our emergency situations. We do have clinics, but they're only in operation for so many hours a day, and then it's closed down. So I'm trying to develop community emergency response teams in the communities to respond to some of these emergencies, and kind of give themselves some self-help in those communities until our professionals arrive. So those are some of the things that I'm trying to implement over the radio programming.
That's great.
I believe that tribal health is also trying to get more, at least partially open clinics in different parts of the reservation. So the healthcare is moving towards the population instead of trying to get the population to come to the healthcare. So I think that's had some limited success.
Yeah, they have 2 clinics that are in operation right now, and 2 of them that should be done here in like a month or 2. Clinics that are in the more populated areas off the reservation. I mean, in the districts, we call them the districts, which is outside of Eagle Butte. We got 2 more clinics that are going up, with one in Red Scaffold and one in La Plante. So our people can access the healthcare systems by going to those clinics. And I like I usually broadcast too the dates that they're open and the times that they're open. Also, the tribal health department is also, buying radio time to get on to talk about their programs. And, a lot of people don't know how to basically even come in and how to, how to access some of those departments' programs that they're implementing. And so they're coming on to the radio station now to try and just tell the people about how to access some of our healthcare systems. And they're also buying, I know our CHR and our diabetes youth program, they purchased some buses that they drive out to the communities and use as a clinic, like to see patients. And, they do specific tests and to bring back to the hospital to try and improve our, assessments of the people with health conditions out there. So that's another improvement that we're seeing here.
Wonderful. That's great to hear about many different strategies being tested in that regard. So we have another question that actually came in through our chat feature, and asking about the concept of you mentioned that this strategy has a focus on trying to get more people to be more engaged with their own health. And the question is, could you expand on kind of what that concept means of being engaged with your own health? What does that mean operationally in the context of this initiative?
With, like I said, a lot of people are distrusting. Like I said, they're not happy with some of the stuff that's, being done here. And then, so we have trouble with people that are distrusting, and we're trying to bring that trust back within this healthcare system by, taking it to them instead of waiting for them to come in, because like you've seen it before, some of them just wait until it's too late, and we're trying to get them in to get seen before it gets too bad. And then, in the past, we've had physicians that came in and, they didn't send them out to a specialist. I think that, we're not sending people to specialists as soon as we could. It's at a later time, and that's when they find out things are a little bit too late to try and do anything about it. So, and again, you know, like they set up appointments and things like that, and for people, and for some reason they don't come in and get seen. You know, I have to do a little bit more research. I think that he answered a lot of those questions by the slideshow here about why some people are very distrusting, and some of them are, you know, like I said, when we were kids, we used to go on hay rides and like go to our neighbor's house. My grandpa used to play piano, so we used to go to a neighbor's house that had a piano, and he'd play music and we played cards. And more social events like that are not happening as much here. And so, you know, we're trying to replace that with some of the activities that these departments are brainstorming and trying to get interaction from the public, you know. So we try to work out of that distrust in the people. So it's a long, hard battle to try and change that.
Excellent points, both the problem of mistrust in the system and the problem of social isolation that you mentioned, that we're learning more and more about what large health consequences those factors have. So excellent points. We've got another question in through our Q&A box asking about access to mental health supports, particularly as it pertains to pediatric populations and pediatric mental health resources. Is that also a focus at all in the work that's happening with the Cheyenne River Tribe?
And in the mental health support system, you know, we've had trouble getting, you know, psychiatrists and experts here on the reservation, you know, to try and help implement some of these programs. So they're working hard at getting some people here to try and implement programs. And we have a new doctor here by the name of Dr. Loescher, and he does a radio program. He calls it Shrink Wrap. He does that every Friday from 3 to 5, and he's interviewing a lot of people and talking about a lot of the problems that the people have here. So, you know, I guess he's reaching out by the radio station too to try and educate people in reference to pediatrics. I haven't heard a lot about that, you know, and you know, I guess I'm not for sure exactly where they're at in reference to pediatric mental health, but I think it's a very growing concern, you know, because some of our suicides that happen now are even becoming younger and younger. I think that, you know, because, I don't know, you know, talking to a lot of these youth around here, you know, because I'm an educator and I'm out there teaching all the time, and I talk to a lot of people in reference to those things. And, you know, a lot of them are, you know, I guess some of them are losing hope for their future, you know, and, you know, they don't think that this place is ever going to improve. So they, you know, they start seeking, you know, suicidal gestures and things like that too, because, you know, they look around and see that, you know, they haven't seen a lot of improvement. So they're, you know, they're very saddened from that. And then seeing, you know, things that happen in our community that are you know, are bothersome to them, you know, and so, you know, those things are very much an important issue, I think, that they need to really implement. And they got some, right now they have they hired a few suicidal prevention people that they're going out and showing videos and talking to people, and they got mental health programs going on. It's just getting those people to come to these programs. And like I said, a lot of times, you know, we're having to do incentives to try and get them to come, to make it worth their while, because like I said, you know, they're coming from the far districts, and then, you know, some of them just don't see the point of spending all that money or what money they have to come up to implement, to take part in some of these programs, you know. So, you know, like I said, we're working hard at trying to take it to them, you know, take these programs to them, but you know, that even gets difficult too, because even working in the health department, you know, sometimes you know, we have GSA vehicles from our health department that we use to go out and do this education, and sometimes there's not enough GSAs to go around for us to do these programs. So sometimes even for the health department, the transportation gets tough, you know. So, you know, like with my programs and stuff, I have to ask way ahead of time in order to get a vehicle so I can make sure I get out to my location that I'm going to do some kind of educational program for the community. So, you know, there are different sectors here, different parts of it that are affecting our ability to try and educate the people in reference to, you know, prevention of suicide and things like that with our with our youth. You know,
Excellent points. Excellent points. I know we're running a little bit long on time. One more question. You had mentioned that another issue is you've got multiple overlapping health systems that are perhaps, you know, imperfectly connected in the context of this tribal population. You've mentioned the tribal public health authority, but you also have the Indian Health Service, a federal authority, and then you've got private providers that are also you know, important sources of care for segments of the population. So I wonder, specifically for either the Indian Health Service or private providers, have you had much success in engaging those two sectors, the non-tribal health sectors, in this initiative today?
You know, we're trying to create, you know, like Kay's done, you know, with us, helping us do that, you know, doing the ice cream social with all the health providers too, and then, you know, and some other ones that Peggy that put together that brought all these healthcare people to come in and discuss these things. But like it said, you know, like they said during the slideshow, you know, a lot of the healthcare systems that are here, like even the private sectors, are finding, you know, I mean, there are so many people, you know, in town here that are scheduling appointments and everything like that, that it's hard for them to get away and come and sit down at the table and talk about some of these problems that we're having, so we can have, you know, a group of people trying to solve problems here. You know, that's kind of a feat in itself too. We got some people to participate, but we're needing more people to participate and work together. So we're still working on that.
Fantastic. Well, I know our time is short. I want to take this opportunity to thank all of our panelists for this presentation today. This has been very revealing about the system alignment challenges and potential solutions in the context of tribal populations today. So again, thank you to David Washburn, thank you to Kay Carpenter, thank you to Harold Tiger for sharing with us what you're learning through this program. I hope this stimulates more ideas and maybe even some new projects. We'd love to get some additional studies looking at these system alignment issues in the context of tribal populations and tribal health and social service systems. So we hopefully we stimulated some ideas and thought that can continue on into the future. Also want to remind folks that this webinar series happens about every 2 weeks. We've got some great upcoming webinars scheduled for next month on the 7th. We'll be hearing from colleagues in the Department of Veterans Affairs and Duke University of testing health and social service alignment strategies for veteran populations. And then also later on the 21st, hearing from our colleagues at Columbia who are testing a new terminology and coding system to facilitate health and social services integration and alignment. So stay tuned, join us at these upcoming webinars. We encourage you to visit our Systems for Action website as well to keep tabs on the growing constellation of research studies that we're supporting, all focused on testing ways of aligning medical, social, and public health systems. So thank you so much. We'll sign off for now and look forward to reconnecting very soon. So long, everybody.
Thank you.